Hello and welcome to Dateline New Haven on WNHH-FM, New Haven's home for community radio. I'm Paul Bass, inviting you to look behind the headlines on the stories that make our community tick. We have two women in today who help people when they're coming out of prison, and they need a medical lifeline, which is an underappreciated part of the challenge of reintegrating people in society. They've been doing it at a George Street clinic called the New Haven Transitions Clinic. And they have some ideas they want the state to know about how we could do a better job based on the work they've been doing. Say good morning to Lisa Puglisi, the director of New Haven Transitions, and Nadine Horton, a research assistant at the center and a longtime person active in our New Haven community. Welcome, folks, and welcome to Dateline New Haven, and welcome back to Nadine.
Thank you.
Oh, it's funny. I'm not hearing Nadine there. Hey, oh, I know why. Okay. How about now, Nadine? Hey.
Can you hear me?
Yep, and now I'm hearing Lisa too.
Fantastic.
All right, well, welcome here. So, your clinic is part of a national network, and does that mean that it's actually a subsidiary of this nonprofit called Transitions Clinic Network, TCN?
Yeah, exactly. So we're one of close to 50 programs across the country. The model started out in California in 2006 and came here over 10 years ago.
And it's its own nonprofit?
It's a collaboration. So it's a number of programs who do the same stuff and learn through the same.
In the one building, and that's in that George Street building right before you get to Park.
Oh, I understand what you're saying. No, it's not a nonprofit. This is a clinical program. So it's in community health centers. Mm-hmm. It's actually not at 300 George. That's where our main offices are. But the program's at Cornell Scott, so we're right on 150 Sargent.
Okay, so the program's right there.
Part of community health centers, which is the whole model, but it's really based around employing community health workers who have themselves been incarcerated in the past.
Oh, okay.
To help people make a connection.
And I'm going to ask you, Lisa, to get so close to that mic, you're almost touching it so we can hear you better. So now I get a better idea. So in the kind of primary care center that the Hill Health and Fairhaven run for Yale New Haven, main place a lot of people get their health care, right on Sargent Drive there. You guys have a program within that.
You got it.
And you hire people who used to be in prison.
Yes.
As health workers to give health care and guide people when they come out of prison. And there's also a research component to this, correct? Yale School of Medicine involved in and is that where you come in, Nathan?
Correct. So I'm a research assistant at the School of Medicine, but I'm also the panel manager at Transitions Clinic.
What does panel manager mean?
So basically, I manage the schedule. I help the community health workers set up appointments for folks recently returning home. When we're actually in clinic on clinic days, I help the doctors make sure we're running on time as best as we can, just to make sure everything's running smoothly. And
so, how many days is this clinic running?
We have somebody there caring for people every day of the week, and we focus a big group who comes in to work on this stuff once a week.
And then how many? We used to have 25 people a day being dropped off in New Haven. I'm sorry, a week dropped off in New Haven from the state prison system. What's that number now? Do you know how many people we have?
The most updated, it's actually hard to get these numbers and hard to get accurate numbers, but I'll say that the most updated number we've seen is about 900 coming back to New Haven yearly.
A year.
And that's probably an underestimate.
And then in your website, you say that there are 10,000 people statewide who return home every year from incarceration. A vast majority are chronically ill.
Yeah.
Now, that's the part that blew me away, because I guess what you're talking, and you also were pointing out that 43% are black, 26% are Latino. So I'm doing my math there. 79% are people of color. So obviously this divorce affects them. But I guess people don't often talk about this. They talk about the need to get a job, training, homes when people come out of prison. I don't hear much about healthcare. Why is healthcare a central point of how we could do a better job with a big unmet need for people coming out of prison?
That's a great question. And I think it's just human nature that it's lower on the list. When you're coming out, you need a roof over your head, you need food, you need to do what probation or parole is telling you need to do. There's lots of natural stressors. There's family reintegration. There's so much on people's plates that healthcare, of course, moves down the list, as it would for anybody. And yet it's dangerous. So the risk of dying after you're released from prison is 12 times higher than people in the community. It's crazy, right?
What kind of period of time are we talking about?
In the first 2 weeks.
Whoa.
So that's out of a big study in Washington State.
A risk of the first two. Wow.
But that's been replicated in many other states as well.
Wow.
And so I'll say that, it is shocking, and it's crazy, just the level of chronic illness and incarcerated people, but it's not actually that surprising. We incarcerate people for having illnesses, right? We incarcerate people around substance use
addiction,
disorders,
that's the big
around mental health conditions.
Right.
And then many develop chronic conditions while they're inside as well, given the built environment, given diet, given all the stressors as well.
That makes sense. So when you're talking about that number of chronically ill, what chronic illness you talk about? You mentioned substance abuse disorder. You mentioned other kinds of mental health disorders. Is it mostly that, or is it other stuff? Is it diabetes?
The vast majority of chronic illnesses are actually overrepresented amongst people who are incarcerated or on community supervision with probation or parole. So they have higher rates of heart disease, hypertension, asthma, et cetera, in addition to the substance use disorders. And
obesity is a big one because of the food that's in these correctional facilities. A lot of folks go in at one weight and they come out exponentially heavier because of the food that they have access to.
Is it also they exercise less? Or some people exercise a lot in prison, right?
It's the lack of exercise now because of COVID. A lot of the facilities went into lockdown. So where they used to have rec time every single day or every single week, because of COVID, they had to lock all of that down. So
they haven't reopened that, given that rates.
It depends on the facility, and it depends on, it really does depend on the facility. Also, if folks are so inclined to, you can, in your little cell, try to do some type of workout. But again, if you're not feeling well and you're feeling, heavier and you don't have access to fresh air or you don't have access to the gym as you used to, there's not a whole lot of incentive for you to exercise. So maybe where you used to be more active in other occasions, now you're not. And because people are scared, they didn't know what was going on. So maybe I don't want to move around because I don't know how prevalent COVID is in the facility. I don't know what's going on. Nobody's telling me. So maybe if I was more inclined to go exercise now, I just want to stay to my cell and to what I know, the little area that I know. So at least I know I'm safe there rather than moving around the facility and not knowing what you're running into.
Well, the main reason we obviously care is because we care human beings' health. It matters. We want people to be healthy. If they're not healthy, we want them to get help. Mm-hmm. Again, in the sense, there's a second reason we want to care is that poor health is a barrier. Unaddressed poor health is a barrier to people reintegrating into society, correct?
To everything.
So
right?
Tell me about that.
What can you do when you're not well? You emphasize that.
So what are you seeing that on the ground, meaning in terms of how big a factor is this in the unmet challenge of reintegrating ex-offenders into society?
It's humongous. I mean, the highest risk of death in those first weeks, and it never goes away, it stays high for months into years, is the risk of overdose. And we're seeing that. I mean, your listeners are seeing that. If they don't know somebody through the grapevine who's overdosed, then it's time to expand the social network. But I mean, it's everywhere, right? And it's especially high risk for this population. So when we're asking people to get a job, do this, all the stipulations of community supervision, it's really hard to do that type of stuff when you're struggling with a substance use disorder that might be coming back at you now that you have some of the old community triggers that used to trigger you in the past that you haven't been around for a long time. The stressors of supervision itself add to it, as does family reunifications, you name it. I mean, the ID issue comes up, trying to get a job. The mark of the criminal record is expansive, and it continues to impact people's lives into perpetuity almost after release. And so that too exacerbates poor health. And then what can you do when you're not feeling well, right? It immensely diminishes your capabilities in terms of reentry.
We're talking about the health care for people coming out of prison and ideas to how to improve it so that improve their chances of successfully reintegrating society. We're talking about that with Nadine Horton and Lisa Puglisi from the New Haven Transitions Clinic, which is part of a national network. And on Sergeant Drive, they give that health care, and you employ, how many formerly incarcerated community health care workers do you employ?
So in New Haven, we had 2. Jerry Smart Jr. passed away a year and a half ago, who's near and dear to our hearts.
I remember Jerry Smart Sr.
Yeah. So, Jerry Smart, he never used the junior, but it's probably
that was the same guy, older
mm-hmm.
gentleman. Okay.
Beautiful person. He was
Yeah.
our senior community health worker for almost a decade.
Okay.
So we now have one, but we also have a community health worker in Hartford at Intercommunity Health Center and in Bridgeport.
So
at
one person
Optimus.
for 900 who are coming out a year.
Yeah, I
Yes.
mean,
Well, do a lot of people find you by being referred by others?
Yes. So because of the phenomenal work that our community health workers do, we get a lot of referrals from all types of community partners. So from discharge planners at the correctional facilities themselves, from the U.S. Attorney's Office, from halfway houses, from family members sometimes who know about the work that we do. So they come in fast and furious all the time. And if you think about the numbers that are coming home, and one community health worker for each of these folks who, by the way, don't just come home with physical health conditions and substance use conditions, but mental health issues, the stress of coming home, particularly if you've been away for a very long time. It's a very different world you're coming home to. So technology issues, there's so many things that they're coming home to. And the community health worker helps them with all of that.
How many other staffs do you have? Doctors, nurses?
So we have two care providers and a nurse practitioner and a physician. Actually, three. So because we have another clinic in Cornell Scott as well, Brian Gallant. And then we have law students who work in our clinic who address civil legal needs of people coming home, barriers to healthy reintegration.
And you run the clinic, right?
I do.
Do you
Yeah.
also see patients?
Yeah.
Yes.
Yeah.
And so now, how many community health workers would you like to have?
So really conservative estimates show that at least 40 for the state.
Now, I know you have a proposal. You're calling for 40 statewide. So
Yeah.
how many would we get in New Haven?
I think, a chunk of that, we're one of the 6 communities in the state that contributes almost 50% of incarcerated people. So we would need, I
12,
want as
yeah.
many as I can get.
And what are you doing with this proposal? So your proposal is to have 40 of these hired, formerly incarcerated people to be community health workers for people coming out of prison. You're doing this with the healthcare unions like SEIU 1199.
Yes.
And your projected would cost less than $5 million a year for
Yes.
these 40 people.
Correct. I mean, community health workers are long tested. I mean, these are healthcare members who are part of teams all over the world.
What does it mean to be a community health worker? Do you need a medical background? Are you
No.
outreach? You learn how to take blood and things like that? Or?
No, not necessarily at all. You're a person of the community who's deeply invested in the community's health and develops skills through trainings. We have a training here at Gateway Community College to know how to interface with people, their health, and the health system. A community health worker does best when they're embedded in a health system because they need access to power. You need to be able to have a person tell you, I'm not doing well, Manya. I think I'm going to relapse. Like, I'm not feeling good. I got too much stress on me. The cravings are coming back. And she has to then have access to get you to that next step, to the care, to the medicines, to the mental health.
So they're the middle person.
Correct.
The
and they're
connector.
so skillful at it. It is a beautiful thing.
So what's the status of this proposal?
That's a good question. It's been proposed.
Oh, there's a bill to the effect?
Yes.
There's been a bill proposed to have the language I don't have in front of me, but it's essentially to get DSS to consider a way and find a way to fund community health workers through Medicaid.
Oh, okay. To find the
I've heard that it's not strongly supported at the state level, which is unfortunate. They are crucial aspects to any health team. And the evidence for community health workers in the health system is abundant. They help with getting people cancer screenings. They help with diabetes.
So obviously it saves us money if they get the work done.
Well, let's be real clear about that. It saves almost every study on community health workers show that they save about $2 for every dollar invested in them. And our study of our transitions right here in Connecticut showed that it saves $2.50 for every dollar invested in the community health worker.
So is there a
this
legislator who has proposed this as a bill?
There is.
Yes.
Are you going to be testifying at Hartford or?
You bet. Absolutely.
So when is that? How could our listeners join?
We don't know yet. We're going to, but we can let you know once.
Yeah,
we
let us
find
know
out.
who the legislator is and what the bill number. We'll put that in the independent. Yeah.
Definitely. And as what happens a lot of times with these public hearings is they get sprung on you like within short notice of when they're going to happen. So it could be a week before it happens. It could be 2 weeks. It could be a few days before it happens. So we will definitely keep you updated.
And you have a second bill that you're talking about, and it was interesting. It didn't say immediately for health, although I guess it's tied in. You want to make sure everyone coming out of prison has a state ID. They might not have a driver's license, but they need a state ID, and that's bill number 5333 in the House. What is the transitions issue here? Just that your patients need that when they're getting services?
So if you think about it, you need an ID to do almost anything. If you don't have an ID, it's almost as if you don't exist.
Right.
So when you're coming home, a lot of times the only thing that folks have in terms of an ID is a prison issued ID. Are you going to want to go around to housing or jobs and say, here's my ID that says I was at Carl Robinson?
And even if you got just a birth certificate, for example, which some people come home with, like that doesn't work. Have you tried to do that? It doesn't go very far in trying to get a job.
No, I definitely understand why ID is essential. I'm wondering what the healthcare tie-in, just because you look holistically at health, that their health isn't going to get better if they don't also have housing, if they don't also have...
Absolutely. Yeah. And there are some real practical things. For example, if you, let's say, are on methadone and you were on it in prison, our state has done a really robust effort in scaling up the access to methadone and other treatments for addiction for incarcerated people. But if you started inside and come home and you don't have an ID when you show up to that clinic, it's just not going to work. And so it does have direct impacts on health in that way in terms of continuity of care. But it's like, it just adds to the mess on top of people that makes health fall lower on their list. And we know that people who are working, getting housing, getting food, getting access to all these things that they need in the community just do better.
And we're talking to Lisa Puglisi and Nadine Horton of New Haven Transitions Clinic. Let me ask you both how you got into this work. Nadine, you've been involved in community stuff. We were talking before on the air about in the neighborhood you're active in off Whaley and Beaver Hills and Dixwell, that right near the prison there's a whole building that might be a nice place to have a reentry set of offices. How did you get involved in the kind of other work you do in the community? How did you get involved with Transitions Clinic and doing the research?
So I originally came on as a research assistant. It's been 5.5 years now. So
time goes so fast. I thought you were just in here for 6 weeks. Okay.
No, I know. Time flies. It feels like I've been there for longer, but I'm absolutely where I'm supposed to be. So I came there 5.5 years ago as a research assistant working on a study around gun violence, mitigating the effects of gun violence in the city of New Haven. So in the course of doing that type of work, and because our team is so integrated, so we don't just silo off into our particular studies, we very much work across studies, we work across fields of interest, et cetera. So I got to know the community health workers and just in talking with them in the office. And then in doing recruitment for studies, a lot of times the community health workers would go out into the field and recruit from halfway houses or folks at clinic that they saw that would qualify for a study. So I got to work really closely with both Jerry and Manya in New Haven. So that's how I got to know more about what the clinic does. And just wanting to go and maybe shadow and just see. I think that's another thing that's important and that Lisa didn't talk about yet, but the fact that the teaching around what goes on at the clinic and working specifically with this population, because it is a very specialized population, the understanding and everything that goes around with that. So I got connected that way. And then unfortunately, when Jerry passed, just stepping in to help kind of run the clinic a little bit better, because we went from 2 phenomenal community health workers to 1. And that's a lot.
During COVID.
One thing I was interested in was how the issue touches you personally. Do you tell me something about your life that makes you care about this? In my neighborhood, which I'm in Whaley, Edgewood, Beaver Hills, the Webb, we have the Whaley Avenue Jail, which is the regional jail. So when folks were literally getting dropped off, a lot of times years ago, we had a huge incident of folks getting dropped off in front of the Whaley Avenue Jail. They're not from New Haven. They have no money. So they were going out to the neighborhood and like breaking into sheds and, just trying to get some funds to get back home or whatever. So we were experiencing a huge uptick in like Isn't that
petty
something?
crimes.
You come out of prison and your first thing is you need to commit a crime to eat.
Well, if you're not from here, I want to get back home. I don't know anybody. What am I going to do? I'm going to fall back on what I know. And do
they now get released at Project Moore?
So Project Moore is the official reentry welcome center of the city. So yes, they do. There is a mechanism in place to help direct folks to the reentry center. But again, talking as a community member, we saw this personally. So trying to help folks, and in our neighborhood, we look for other alternatives. So we don't look to like locking folks up. We're like, okay, how can we help these folks? What can we do? What can we as a community do? So we were trying to reach out to different folks, like, how can we help these people? What can we do? So that's how I got involved as like a community person. And then the other thing is we have a community garden there that's right next to the Whaley Ave jail. So we're regularly seeing folks, sometimes folks would come down the street, or, correctional officers would drive down the street. And, so there's lots of organic ways for us to interact with kind of that system of folks coming home. So it touched us personally because, again, we were seeing folks coming into our neighborhoods, and we wanted to find a way to help them and direct them somewhere where they could get credible, practical help.
Mm-hmm. So it's touched you as someone who lives in a neighborhood, and you saw the impact
Saw
of
it
there not
personally.
being enough support.
Dude,
So
very
you're
little.
doing research as well. In addition to help make the center work, what's something you're researching? You do studies with people come back from prison on their health care?
Yes. So the study that I'm on now is called the Justice Study, and it looks to speak to folks who have recently been released from prison or jail within the last 3 months and suffer from a chronic health condition like high blood pressure, high cholesterol, pre-diabetes, diabetes, or are overweight, and to see how the conditions while they were incarcerated, so their lack of exercise, the diet that they ate, the lack of access to health care, how those things made their conditions worse, because those are all factors of cardiovascular disease.
And that is in conjunction with the Yale School of Medicine?
Correct.
And what's the Yale School of Medicine's role in the clinic? Are they a partner, or is it in conjunction with them, staffers?
We all who run the clinic work for Yale School of Medicine.
Are you all employees of Yale
And
School
they
of
have
Medicine?
deeply invested in our center, the SACE Center for Health and Justice. So this is a big institutionally supported group of researchers, doctors, community health workers, lawyers, you name
This is
it.
an obvious question, but what do you hope comes out of this study? What's the reason to be looking at the people in the first 3 months coming out who have these
So many.
medical conditions?
So many. A big thing is a lot of these things are preventable. So diabetes is preventable. It was funny. I was just talking to a participant the other day and talking to him about folks that he knew who were pre-diabetic or diabetic, and he is having some, issues, and just they're losing limbs, they're losing vision, and it's all preventable. We hear folks who have recently passed, they're in their early 50s or early 40s, and they don't have to die. But again, if you're coming home and if you're used to, while you're incarcerated, your meds are given to you, you're used to being called down for healthcare needs. Now you're coming home and all of that falls on you. Again, that brings it back to where the community healthcare worker really can help navigate that. Because if you're coming home, what do I do for prescriptions? What do I do for a doctor's appointment? Is it going to take me 3 months to see somebody? One of the hallmarks of our clinic is that we try to get folks in within 2 weeks of their release. That's unheard of.
So the
Usually
value
takes
of the
months.
research, like earlier when you're making the case from our healthcare workers, Dr. Bleasy talked about the $2.50 return on every dollar you spend. What can be done with the data you're coming up with so that in the end we can get more help for people? Is it something you present to legislators to fund this stuff?
Yeah, and I mean the other opportunity is to think about programs. Like we're studying this and we're finding that psychosocial stress after release is associated with worsening of heart disease and cardiovascular risk factors. So that opens a huge door to say, what can you do at a system level to intervene on this, to mitigate some of the psychosocial stress, to improve outcomes? I'm talking about stuff like universal basic income programs. I'm talking about system-wide health system programs like community health workers for everyone who's been incarcerated, right? I'm
So it's
talking about
programmatic.
housing programs. Like, what about if you house people?
Laws.
If we as a city invest in people and house them after release, you've been housing them for the years that they were incarcerated, and now it's okay not to, right? But if we help with housing, how does that then mitigate this risk and improve health? And
So
let's
you're
be
hoping
real.
the data you're hoping can not only make a case for what needs to be done, but help you figure out specifically what kind of help people will make the difference.
Absolutely. And let's be real clear, crystal clear, that this is a health equity issue. 70% and upwards of people incarcerated in the state and coming home are Black and Latina, right? And so when we say things like we want to improve health equity, what that means in practicalities, you have to invest in people, right? And you have to actually dedicate funds to caring for people. And this is how you get health equity. So investing in community health workers and any of these programs that we mentioned is a direct investment in achieving health equity in our state.
Lisa, tell me about your own pathway. So you're both a professor at Yale, or assistant professor, a researcher, and a doctor who actually takes care of people. Has that been your whole career? How did you get into medicine? How did you end up focused so much on the ex-offender population?
I'm like, someone who's always late to the game a little bit. So no, my path has been very circuitous, and I kind of figure out things as I go. It's just...
Where'd you grow up?
I grew up in New Haven partly, and then in Boston.
You're related to Puglisi's, like Judy Puglisi, the principal? No.
Lou Puglisi is my father-in-law, who was a superintendent in New Haven for years and a teacher at Troop and Sheridan and science teacher, you name it. I have patients who are like, wait, are you related to Mr. Puglisi? He was nice to me. Barbara Puglisi is my mother-in-law. She works over at Riverside. She's a teacher in the city for decades.
She came from a caring family, helping family. And
but it's not, you know what, sometimes people say like, oh, you're doing, God's work or this type of thing. It's not that. This is just necessary work, and it's joyful work. I'm not doing anything to be nice.
It's common sense work.
Yeah, it's common sense work, and we have the greatest patients. Like, these are people with tremendous assets.
So tell me a story about a patient, somebody either studied or someone you helped.
I'll tell you a beautiful story. I saw somebody the other day who said to me, Puglisi, I don't think you like seeing me anymore. And I said, why'd you say that? He said, I think it makes you too sad now that Jerry died. And I said, wow. I said, you know what? It does, I feel sad all the time when I think about Jerry dying, but I love seeing you. And I'm like, do you know, the amount of effort me and Jerry put into you as how much we loved you and cared? All the things Jerry did when you first came home years ago to help you get those jobs and to help, get things straight.
So this person's been coming for years.
Oh, yeah. I've known him for years
So how
now.
long do they come to the clinic if you're an ex-offender?
I'm their primary care doctor.
Oh,
yeah.
okay.
So you're stuck with me unless
And
you
how's
wanna
this
leave.
person doing? What's this person?
He is so special. He is a single father. We helped him do some of that paperwork and all that stuff. And he is now raising a daughter who's graduating from high school this year, going to go into nursing school. And I was like, do you know what joy it brings me to see you having raised your daughter like that as a beautiful father who's working 2 jobs and have a daughter going to nursing school? That's what Jerry wanted. He is somewhere so proud of you. And so, but this patient is not a unique story. We incarcerate people who have tremendous assets, who are artists, writers, scholars, thinkers, laborers, tradespeople, and fathers.
Are so much more than their charge.
Mothers.
So they're not, when we see them, one of the first things I say when I'm working with them is I'm talking to the person who's in front of me right now. We don't look up what they've done. We don't care about their record. I'm talking to the person who's in front of me right now. So and I always tell them, you are so much more than your charge. So don't think of yourself that way. Family may see you that way, community you're coming back into may see you that way, but just go from this point forward. Who you are today, sitting in front of me now, that's the point that you start
Nadine,
from.
can you tell me a story about one day of something that made a difference when you see this, why I do the job? This is how it makes a difference. Here's what we're up against.
So I have several, but one I can think of off the top of my head is a participant who came to me. He just finished the study. So this is a 12-month study. When he came, he was he was early in his recovery. So he was really trying to focus on staying clean and sober. All throughout the study, just check in, making sure he had primary health care, which was very important. He got connected to groups. He got connected to, physicians and clinicians who could help him with his recovery. And one of the things he was so focused on is making sure he always gave back. So reaching back to people who were also coming home, who were in the halfway house with him. He really wanted to do that work. Now that person is a counselor on board at a substance use organization in the city and is still continuing to give back. And I was so happy to be able to give a referral for him to get that job. He was like, can I please put you down as a referral? I said, absolutely. They called, they talked to me. I talked to them about it. And he got that position and he is doing phenomenal work, and I'm so very, very proud of him.
Teamwork makes the dream work. Because every time I hear you tell stories, it's not just about yourselves. It's about the different people you work with,
Absolutely.
including the people coming out of prison.
You got it.
Well, good work. Anything
Thanks,
before
Paul.
we thank you for joining us? Tell us about the important work you're doing. How can people help or get involved?
Contact their legislators about the House Bill 5333, which is the state ID issue, and then we will definitely loop back and let folks know how they can get on board with the community health worker bill.
All right. Anything final thoughts you want us to about how we think about this issue in our time? You raised my awareness a lot today.
We're just grateful for this opportunity. Thank you for spotlighting this issue. And we have a lot of work to do in this state. I think we do it together. We're not here just for transitions. We're here part of a whole justice reinvestment group. And I think we do the best when we work together. That means working with the DOC to improve this transition home and really helping the community. The community health system's not perfect either. We got a lot of problems in our own home. And so it's uplifting the community health system, the correctional health system, and all these community organizations which are doing incredible work.
And working together, we can make a difference.
All right. Nadine Horton, it's always a pleasure talking to you. Lisa Puglisi. Sorry.
Nice
It was
to talk
great
to you
to
again,
meet
Paul.
you.
It was nice to meet you.
Thanks to Harry Droz, the station manager, keeping us firing all cylinders. We're going to take it out with the Afro-Semitic Experience performing I Wish I Knew How It Would Feel to Be Free from the group CD, A Plea for Peace. This is Paul Bass inviting you to fly free with us all day, all night, and all weekend long on WNHH, New Haven's home for community radio.